And this is important because pregnant lady is, when it has a severe problem, it has high-risk problem, the pregnant lady is a special person. It's a person who is awake, who knows what happened around, and when we have this lady who has, for example, a cardiac problem, and if you put this lady in intensive care unit, first the intensivists don't like to have this lady because he said, no, it's not a big problem, but we know that it's a big problem, that the combination of one disease and pregnancy. We know that it's a big problem. And in another side, in the intensive care unit is the unit where there are elderly people, very severe cases, and it's not a good environment for pregnant ladies. And that's the reason because we think that to care high-risk pregnancy, it is important to have this special care unit. And of course, the differences between a special care unit and intensive care unit is that intensive care unit, they have the aggressive and continuous treatment and invasive mechanical ventilation, support for 2 or more organs, high-skilled nursing there. They are very invasive. And it's a very severe preeclamptic lady. You need just to have a control, to control the blood pressure, but not to be invasive with the lady, just to have a good result. But how you can manage that? Okay, you say, I think that all the hospital who has an obstetrics department must have into the hospital, into this department, this special care unit to put all the ladies who are at risk. We need just to think, it is necessary to have intensivist obstetricians or intensivists with the knowledge of obstetrics. Or maybe it is not necessary to have another specialty into our specialty obstetrics that could be called critical obstetrics as a new specialty. Because when I think in the OBGYN department, when you are looking gyne, when you look at the gyne department has gynecology and endocrinology, gyne oncology, fertility and sterility, mini invasive department have many divisions, many subspecialties. And obstetrician, in obstetrics, they put all together. We know there are high-risk pregnancy and low-risk pregnancy, but they are all together. There are not subspecialties, only maternal fetal medicine. And maternal fetal medicine, you know, is more fetal medicine than maternal medicine. That means, this is my thought. I like to share with you and also to hear your comments, especially for Professor Chevan and for my friend Amos that is there. How do you think to have these special places where everybody, the ladies can have a special environment and doctors, consultants and doctors in training can find a place that they can learn during intensively how to manage high-risk pregnancy and how to manage different disease and to know about cardiac problems, kidney problems, and all the problems apart from pregnancy. And looking also to the literature, I found that there is a program in the University of Mexico that is a special program about critical obstetrics. And it is evident that somebody also in the world are thinking about that. And also in this country, there are some training things, this university, Columbia University, and I just look into the literature. There are many courses or training courses for obstetrics teams in critical obstetrics. But most of those courses, like in Argentina at that time, are managed for the intensive care unit societies and all the intensivists who teach and to give lectures to obstetricians. And I think the reverse. I think that we need just to train it into the obstetrics environment and to make very good skilled doctors just to manage the ladies who is at risk. That, of course, requires consideration of socioeconomic status and the health center of choice to make this unit, but I think that we have much to learn, but there are new tests, recent tests that give hope, and we can propose new challenge in obstetrics, especially in obstetrics with pregnancy, just to save the pregnant ladies and to save life. That is the most important point. Okay, thank you very much for your attention, and I'm ready for your question and your comments. Thank you.
Liliana, let Mehmet have the first comment, please.
Thank you very much for this wonderful talk. And actually, in the United States, there is such a critical care obstetrics program that is approved by the American Board of Obstetricians and Gynecologists. And actually, one of my fellows, the reason I know is that I helped one of my fellows to get such approval, because you really have to tailor, and the requirement is that you serve 1 year in a critical care department, and I think 2 months doing anesthesiology rotation, in addition to the MFM. The only problem that she faced afterwards is that you need to find a very special setting to work at, because most hospitals do not have the number of very high acuity patients that would occupy the full-time obstetricians. So, but there is such a program, and what she does is that she has to continuously rotate through intensive care to keep her skills up to date. Otherwise, she won't be able. So it's a challenge, though.
Okay, thank you. Thank you for your comments. I think this, yes, of course. I think that one of the problems is that you need to have maybe a reference hospital that to have these special units, maybe, because sometimes what you say is true. They said only 10% of the ladies, of the pregnant ladies, are at risk, and in economical terms, to have a unit in that condition, maybe it's not a very good economical things for hospitals. But I think like in my country that the hospital belongs to the public service, and I said in our department, for example, because it's a big hospital, the hospital is high risk pregnant ladies and everybody, of course, are coming to the big hospital. But between all of this population, there are pregnant ladies too that are coming to the other departments and have important problems. And we move these ladies to our department and to taking care, especially that the ladies in our departments. For example, a lady who has antiphospholipid syndrome, and they are diagnosed before pregnancy, they are moving to our department and this special unit and are taking care for us, because we need just to check in every day how the baby is going. And we got also the hematology doctors that belong to our department, that are working with us every day, and also the nephrologists that are working with us every day. I think it is very interesting how the residents doctor who are training in our department, they have an open mind of all the disease that could be happen during pregnancy. And when we made a comparison with other hospitals that has not this kind of training, some big problems happen, and many ladies really become very illness, very big at risk because of that. I think it is very important that we have here a program. I didn't find in the literature. It belongs to the American College program?
It's approved by the American College.
Approved by American College. I was just looking.
Board certified.
Okay, it's very interesting.
Liliana, let me pick up with Mehmet's comment. The year was 1991. when Maureen Drusen had left and I was named Director of Maternal Fetal Medicine. And on the theme that you're saying, one of my first initiatives, I said, wouldn't it be great to have a critical care MFM here? But when I looked into it, it was the concerns that Mehmet raised came to the force. The cost would be great, and we just didn't have the volume. We're blessed here that we have wonderful consultants. Phyllis August is here. So we can manage so many of our cases collaboratively with excellent internists and surgeons, and there are so few that are actually need the true critical care, intensive care experience, and I've been won over that I think those patients are better managed by those who work full-time in the intensive care unit, with us then, in effect, being the consultants. So I've gone over to that side. At least that works here. Now, when Baha Sabai was in Tennessee, I mean, that was the quintessential example. When he had a ward of his preeclamptics and eclamptics, that was true critical care. But there are very few units. So Phyllis, can you comment on this? Help me.
I think for our hospital, I agree with you. I don't think we have the need because most of the patients we deliver here have really great antepartum care, and we don't get those transfers like from the bus from the Bronx here, in terrible shape. But I certainly could see, it sounds like a wonderful idea in the setting.
To be honest,
a different setting. I don't think we need it here. For the reasons that you said, is that our patients, those kinds of cases are few and far between, thanks to the excellent antepartum care that they get.
And we're very fortunate. And Phyllis, can I say this? I mean this. One thing that dawned on me from the moment I came here, what a great relationship we have with you and others in this center. It's very unusual. We have great relationship with internal medicine and the other specialties, so we work collaboratively very closely, so we don't feel the need to possess it. We have true collaboration, and that's not just words, that's the reality, Phyllis, as we know. Can we let Dr. Grunbaum have the next word?
I just thought one part was very important, that 40% of your maternal death were due to septic abortions. And that's something we do not see in this country, in this city anymore as much as we used to see. When I looked at old numbers before 1973, before the Supreme Court decision on making abortions legal, 40–50% of all maternal deaths were septic abortions.
Yeah.
And this is actually something that's when the discussion about abortions comes up again and again, that women's lives are being saved if abortions are legal and safe. And is there any chance in Argentina to save women's lives by making abortions legal and safe?
I don't think so. I don't think so that will be happening. But the problem with this high maternal death because of septic abortion that we see at one of the pictures that I showed today is Jujuy province. And Jujuy province is very close to Catamarca province. It's a province from this northwest of Argentina. That this the real problem in that province is social problems, violence, and very poor people that really they are not coming to the hospitals, and we need just to work more in the community with that people. We just to reach, because we have a very good program with anti-conception program. This is a very, very good program. We can just give to anybody anti-conceptions, for example, without any problem. And also the lady, when I leave the hospital after delivery, we just give the anticonceptive pills, or to put the IUD, or to make the counseling about what they do. The problem in this province is there not a very good work into the community, just to reduce this problem with the septic problem. And when you say it's in the other part of the lady who are coming to illegal abortion, now they are just taking misoprostol. They are coming to the hospital to finish the to deliver this missed abortion legally at the hospital, but they start making at home, just taking the pill. I'm not quite sure that there could be have any change in Argentina for the moment. The government for the moment, they didn't support the legal abortion. They just try to support pregnancy. And I think it's not easier in a big country like Argentina with very few people, because it's only 40 million, so it's a very big country, to have an abortion law. Maybe the first advance in that order is to depenalize the abortion. That means if the lady came to the hospital because she has a problem, because she started making an abortion illegally, and she came to the hospital, we are not, I don't know exactly the word in English, is judicialize the problem, just to take the lady to the court.
To decriminalize.
To decriminalize, that's the name. Now is the law to decriminalize the illegal abortion. I said, if the lady has, okay, it's okay, it's not decriminalized, not criminalize the lady, because I remember in the past some policeman was in front of the lady room when the lady were coming with Mondor syndrome, for example. But that is reduced at the moment. We have a high-risk hospital with third-level hospital, and in the last 10 years, I see at least sometimes one case in a year, and in the past we see one case in a month for Mondor syndrome. I'm going to say about the special care unit. I say we have a very good relation with intensivists, very good relation. But I say it's a different thing. Intensive care unit, we send the ladies to intensive care unit. You see, 15 ladies a year at least are going to intensive care unit. But that's where the lady under shock, the lady who need ventilated respiration, those kind of ladies. But the other ladies that are away, that they can walk, but we know that they have very severe problems, they are kept all together in this special care unit. This is the thought about intensive care unit. The nephrologists are coming every day. The ladies are coming to the nephrology department to make the dialysis every day, and we are working together. It's a very nice team, because we learn too much from the intensivists and from the different specialties, and we learn too much about the fetus also, because you know that the fetus has all these problems that the adults have. And sometimes we forgot about medicine, but you need just to apply the same concept to the fetus, when the fetus is inside and is intrauterine growth retardation, and maybe has some kidney disease, and we just don't need to find nothing new. It's the same problem, but in different way. And we learn a lot from the intensive people.
Liliana, this was brilliant. You've been a wonderful guest. We'll have you back again. Thank you so much.
Thank you very much. Thank you for the invitation. Thank you. Oh, thank you, Frank. Thank you. Thank you very much.
No, this was perfect. This is a good audience. This is a great one.
Okay.
Wonderful.
Thank you very much.
And even Phyllis came.
In the middle.
She's our medical consultant. She's wonderful. She's wonderful. She's wonderful. She's wonderful. Yes. She's wonderful. Mehmet.